It's past the hour, so we can go ahead and get started as people continue to filter in. Welcome to this Pain Research Forum webinar on osteoarthritis. I'm Adam Dorson, working with ISP and PRF. I'm just going to give a few brief announcements. You are on this webinar shown here. Some guidelines for this webinar. We very much encourage questions. You can submit these through the Q&A button on your computer, and they'll come to the panelists, and we'll have 3 talks, and hopefully time for questions after each talk. If they're not able to be answered live, they can be answered in text. And then if we have time at the end, we can open it up as a panel discussion. If you need to, as an access, you can zoom in on your actual screen to see closer. And then when we're done with this is a recorded presentation, and it'll be posted on our website as well as on our YouTube channel. As an announcement, we have an upcoming live event. This is one of our signature journal clubs from our special interest groups. This one is orofacial and pain, orofacial and head pain. So we have a fantastic paper and a speaker coming up. We very much encourage anybody to join, but very much so if you're interested in this topic. And especially encourage trainees. This is usually a very lively discussion, so it's a very fun event. We also have a ton of other content on our website, including podcasts and interviews, so I encourage you to check those out. And with that, we can go ahead and get started on today. So I'll stop sharing and hand it over to you, Ewan, to moderate this session.
Great. So depending on where you are right now, good morning, good afternoon, or perhaps good evening. My name is Ewan Smith. I'm in the Department of Pharmacology in Cambridge, and I'm delighted to welcome you to this Pain Research Forum on Osteoarthritis Pain Research webinar. We've got 3 speakers who tackle the complexity of OA from different angles in different species, and so it'll be exciting to hear what everyone has to say. And we'll begin with Duncan Lascelles, who did his veterinary training here in the UK, including a stint, I believe, in Cambridge, before heading to the US, where he's currently Distinguished Professor of Musculoskeletal Health and Professor of Translational Research in pain and surgery at North Carolina State University. His research develops methods to measure pain associated with spontaneous disease in animals and the underlying neurobiology, with the overall goal of improving pain management in companion animals and facilitating analgesic development in human medicine. So Duncan, the floor, or rather the screen, is all yours. I will put myself on mute, and thank you very much.
Thank you very much for that introduction, and hello everyone. It's a pleasure to be part of this and to kick this off. Now, I'm going to present a concept. I'm not going to present data, rather a concept. And the concept is all around how naturally occurring pain in pets can contribute to human pain alleviation. And I want you to think of this concept I'm presenting as not a replacement, but an idea for enrichment of the translational research paradigm. Now, for full disclosure, I'm not going to talk about anything that is related to a conflict of interest here, but I have funded research from a number of entities, primarily the federal government through NIH grants. I also do consulting for a number of entities as well. I guess the first question here is why use pets and other large animals, I'll touch on that at the end, with naturally occurring painful disease? And so I'm going to go through a bit of an argument that I'm sure a lot of you are very familiar with. And that starts with the economic impact of persistent pain. It is huge. People have put figures of hundreds of billions of dollars on it each year as the economic impact in the US. A large part of persistent pain is related to osteoarthritis and musculoskeletal pain. And because it's important, there has quite rightly been an exponential increase in the amount of research in this area. Now, this is a graph I took from Natalie Percy-Doucet, Andrew Rice's publication from a few years ago, and I just added in a bar for 2023. And these are the number of publications actually related to neuropathic pain. But I think in any other area, you see this exponential increase in research. So that's great. But overall, there has been a failure to develop new or novel non-opioid analgesics for persistent pain states. Now, we can debate that back and forth, but really, given the importance of persistent pain, including musculoskeletal pain, given the exponential increase in research, we've not pushed much across that finish line. And as was recently said, despite generating a plethora of novel analgesic targets, pharmaceuticals for chronic pain treatment remain largely limited to the same drug classes as 40 years ago. So, how can we do better? Well, I guess the first question then is, where does translational pain research go wrong? And if you think about this chart here, so this would be human pain therapeutic development. We identify targets, compounds, establish activity in various models, rodent models. Once we have a putative analgesic, a signaling system we're going to target, then there comes the important safety testing, currently mandated to be in two species, a rodent and a non-rodent species, and then we move into human clinical trials. So essentially, it's discovery in rodents, in rodent models, safety tested in animals, and then into human clinical trials, where phase one is safety, and then we get into phase two, which is dose determination and initial efficacy. And I think, if you think about this leap, if we just think about activity, this leap from activity, efficacy in rodent models to human clinical trials, that's quite a big leap. Arguably, there's a bit of a chasm there between those two. And so I don't want to dwell on the issues. I want to turn this question around. Instead of where does preclinical translational pain research go wrong, where could preclinical translational research benefit? And again, really focusing on enriching the translational research paradigm, not replacement. And I think if we look at this, and lots of people have written about this, we could do better with the models, the pain state, the outcome measures used in the models. I mean, don't get me on my little hobby horse about von Frey and reflexive assays. And then the relevance of the target. That's something that's not talked about as much, but I think that's important. And I'm going to touch on these three areas. And what I would like to posit is that naturally occurring painful disease models, now we're talking about pets with naturally occurring disease that is painful, I'm going to call them models, may better reflect the complex genetic, environmental, temporal, physiological, and psychological influences present in humans. So in many respects, these naturally occurring pain states are beautiful models of the variation and complexity of the human condition. Therein also lies the problem. They are complex and varied. They are not a C57 mouse with DMM surgery-induced osteoarthritis in one stifle joint. These are complex, and so there's a bit of a push-pull here. I mean, in many respects, these models really do reflect the human condition, but that is also the difficult part. And if we focus on osteoarthritis pain just for a second, the osteoarthritis pain in naturally occurring osteoarthritis pain in pets is very similar to osteoarthritis pain in humans. In terms of the fidelity, biomechanically, structurally, histologically, genomically, and molecularly, human, canine, feline, and equine OA are very similar. The burden is similar to humans. So just if you see the radiographs come up there, one of those is the coxofemoral joint of a dog. The other happens to be my coxofemoral joint on the right side prior to total hip replacement. So looks very similar. The burden is very similar. These two charts that have come up here reflect the burden of number of joints affected. And so the lightest piece of the pie there, 37 in humans, 36 in pet dogs, that's no joints affected. Then we get into 1, 2, 3, and so on. And these pies, I mean, just look at them. They look so similar. So the burden of multi-joint OA is very similar. And similar to humans, osteoarthritis in companion animals is very common. Probably about 40% of all dogs and cats across the age range have not just the disease of OA, but OA-associated pain. And so I think, I would argue that the model is very similar. There's high fidelity across the species here, dog, cat, horse to human. But the model is only going to be useful if we can measure the impact of pain associated with this. So we think about the dimensions that are impacted by pain in humans, and this is one way of illustrating those. So chronic pain, well, what this figure illustrates is that chronic pain is impacting multiple dimensions or areas, gait, movement, function, which obviously is related to gait and movement, the ability to move, sleep, uh, cognitive function, affective states and cognition, social relationships. So these are the dimensions. Everyone has a different way of presenting these, but these are the dimensions that are negatively impacted by pain. And the arrows are two-way because there's a two-way relationship. Poor sleep induced by chronic pain actually will heighten the pain experience in individuals. And so, as we think about this, we think, okay, so if this model, this complex, varied model in pets is going to be useful, we need to be able to measure these dimensions. And we can. Starting at the top left there, we can actually very well, arguably, much more easily and with more accuracy than in rodents, we can measure limb use in dogs using force plates, pressure-sensitive walkways. And so we can get a very accurate readout on the impact of joint pain on limb use. Moving to the center, thinking about function, we have, over the last couple of decades, developed and validated proxy questionnaires. Those are owner questionnaires about function of these pets in the home environment. Moving across to the top right, we've done a lot of work developing and establishing quantitative sensory testing, mechanical, hot thermal, cold thermal, quantitative sensory testing in dogs, just as it's done in humans. And we've even taken that further. We can measure, use QST to get a handle on central sensitization. Below that, this chart here is a 24-hour profile of activity. We will use activity monitors to get an objective measure of movement, not only total amount of movement, but patterns of movement. And here you're seeing the influence of joint pain, increasing joint pain in individuals on that 24-hour pattern of movement. More recently, at the bottom left here, we have been using and developing other measures of cognitive function. So looking at the impact of pain on cognitive function, and then also the bottom right on affect, on various components of affect. And this is work that I have been doing recently in collaboration with Dr. Margaret Gruen, a behavioralist at NC State. And so I think if you accept there's fidelity there, if you accept that osteoarthritis pain is similar, dogs, cats, horses, and humans, and if you accept that we can measure the impact of pain on these individuals, we have our outcome measures, then a great place to insert, I say, enrich the translational research paradigm is to insert studies in pet animals to help inform that critical go, no-go decision-making point. What I'm talking about here is you take a putative analgesic and you test whether or not you're seeing efficacy carried forward from the induced rodent models into these naturally occurring complex model states to help decide what should move ahead into human clinical trials. Now, the other aspect of this is if we can measure the impact of pain, then we have the opportunity to contribute to discovery, or at least look at the face validity of the target. What I'm talking about here is we usually identify targets in rodent models. We induce the rodent model, do a deep dive into the signaling systems that are altered and pick our target. Well, we can use tissue from these naturally occurring pain states to check that target, to ask the question, is it actually valid? Is it important in the naturally occurring disease state? And the argument behind this is companion animals can be pain phenotyped. Veterinarians, and I'm a veterinarian, have unprecedented access to biological samples. And with that access, just samples in well-phenotyped animals, we can then interrogate target tissues for the target of interest, or in an unbiased way, a kind of an omic type approach. And actually, our moderator today, Ewan St. John Smith, wrote this beautiful, well, he was a senior author on this beautiful review here, basically saying, look, we take tissues from all these rodent models and use them ex vivo. Why don't we do this from animals? And he was talking about large animals, but I think including companion animals. Why don't we do the same approach using these tissues from large animals and naturally occurring pain models? And, so just to push this home, as a surgeon, I'm engaged in total hip replacements. That gives us the opportunity to take the tissue that's you're normally taken out and thrown away at surgery and use that for these types of investigative approaches. Other surgeries, we have similar access to tissues. Animals are euthanized. Different to humans, animals are euthanized. And again, if we have those animals phenotyped, then here you can see I've taken off the dorsal part of the spinal column, about to pull out the dorsal root ganglion, caudal dorsal root ganglion, and the spinal cord. Then these tissues from these well-phenotyped animals are banked and interrogated. So 3 ways in which companion animals can contribute to translational pain research: a bridge between rodent preclinical and human clinical studies. This number 3 there, discovery, or looking at face validity of the target. And then what I didn't talk about was they can help us understand disease etiology and risk factors. Again, it's all about enriching the translational pain research paradigm. And with that, I should thank the incredible team and collaborators I work with, and I'll finish there.
Thank you very much, Duncan. So if you have questions, please do put them into the Q&A. And there's one already which I'll kick off with and put across to you, Duncan, which picks up, I think, on your point number 2. So the question essentially is that dog and cat OA might exhibit similar sort of phenotypes to human OA conditions in terms of prevalence of multi-joints and so forth, but there's limited evidence about the similarities of molecular mechanisms. And I wondered if you could perhaps comment on what you think the molecular mechanism similarity might be between, say, studying dog OA and human OA compared to mouse. Is it going to be similarly different, or do you think the dog might provide a sort of in-between, closer to a human than a mouse? I mean, what are your general thoughts, and what do we already know?
Yeah, I think it's fair, starting with the last part of your question, I think it's fair to say that we don't know a great deal, because I think people have not yet taken the opportunity to take those tissues from the naturally occurring pain state and interrogate them on a cellular and molecular basis. But what we do know so far, I think, is telling us that that it is going to be exactly what you said. You hit the nail on the head. They're going to sit in between. There are going to be similarities, which I think we can then leverage. There are going to be differences, which are going to be important to understand. Not that no one model is going to be perfect.
And while we're waiting for anyone else to put questions in, just one I've always wondered about is obviously most of us are working with C57 Black 6 mice, and that's brilliant in one sense because every mouse is identical, so we've controlled for massive variability. And I guess with dogs are sort of halfway in between, because you've got different dog breeds which might be more similar to each other. And I just wondered if I was sitting here now thinking, okay, well, Cambridge has a large veterinary clinic. Are there, based on your experience, are there particular breeds that we should focus on, or should we be breed agnostic and study in general? What are from your experience, if you're encouraging someone to get into the dog OA field as a way of mining molecular mechanisms, what would be your advice from your experience thus far?
As always, you're always at the forefront of what's happening in our understanding. So I think so far we have been rather agnostic to breeds. I think we're now starting to understand that we should actually, in certain circumstances, factor in different breeds. And so I think, it really depends what the question is. I think to answer some questions, we can look across breeds. To answer other questions, we probably want to look within a breed, depending, again, on what that question is.
Okay, thank you. And then one final question from Michael Gold, who's asking a question very close to my heart, being someone who works with mole rats. Have you found issues with tools such as antibodies? So if you're getting at your dog DRG, can you go to what works for mouse, human? So is it just random luck as what works, or do mouse things tend to work? What's your general experience so far? Again, for those of us who might want to leap into this field.
Yes, great. That's a great question to bring up, Dr. Gold. And Yes, there are issues, there are problems. I think every time we start to look at our antibody of interest, we need to validate that it's actually hitting the target. I think there are some times when we just really struggle to get the antibody tools that we need. But I think omics is giving us a different approach, almost a way around that, particularly with the canine genome being relatively well annotated. And so now, whether it's proteomics, metabolomics, genomics, we actually have almost a way around that in some respects.
Brilliant. Okay, thank you very much. So we're going to move on to our second speaker now. So Tuhina Neogi, trained in Canada for MD, the US for PhD, being rheumatologist and epidemiologist, currently serving as section chief of rheumatology and professor at Boston University School of Medicine. And Tuhina has developed a research focus on risk factors for NeoA and gout, as well as pain mechanisms in osteoarthritis. For her research, been recognized with numerous prizes, including the 2022 Orsay Clinical Research Award, has been a past chair of the FDA Arthritis Advisory Committee. So Tuhina, we look forward to hearing more about your work, and I'll pass over to you. Thank you.
Great, thank you. Are you able to see the full?
Yep, all good. Go for it.
Great. Okay, well, thank you for this invitation to speak with, as you said, across species. So I'm going to be focusing on clinical research. And clinically, the big conundrum in osteoarthritis research has been this so-called structure symptom discordance in knee osteoarthritis, where some people have pain, but not much structurally abnormal. Others have terrible looking x-rays, but not many symptoms. And so the overlap between those with symptoms and those with radiographic OA is incomplete. And this is a really important public health burden because around 600 million people have osteoarthritis, according to the Global Burden of Disease surveys, and 10 to 15% of adults, with the knee being the most common site. So why might there be this structure symptom discordance? Well, first, we know that there are structures in the knee that contribute to pain. And this study, which is now over a quarter century old, is a study in which an orthopedic surgeon interrogated in an unanesthetized arthroscopic fashion the knee of his orthopedic surgeon brother. We don't know which one is older or younger. And not surprisingly, as expected, certain tissues were painful when interrogated. Infrapatellar fat pad, ligaments, synovium, outer aspects of the meniscus. But importantly, what was not painful when interrogated was healthy cartilage, which we know is aneural. They didn't interrogate bone because we know that bone is painful. And so how does this translate on a population level? For me, as a rheumatologist and epidemiologist, I took this question as how do we detect the signal on a population level when all population level studies seem to have shown the structure symptom discordance? So what I did was I took it as an epidemiologist as an issue of between person confounding. So if we could eliminate all the differences between people, can we see this kind of finding on an individual level across a population? So what I did is I took two cohorts, the multi-center osteoarthritis study and the Framingham Heart study, and took people who have pain in one knee and no pain in the other knee. So in this way, any difference between the two knees must be at the knee level. All the genetics, the obesity, sleep deprivation, anything that might be affecting pain is controlled for in this manner. And when you do that, across the x-axis here is the radiographic severity of OA, with Kelvin and Lawrence grade 2 being definitive OA. And you can see a very nice dose-response relationship between radiographic severity and likelihood of pain, and including very, very high odds ratios. So definitely structure contributes to knee pain, but we still have the structure symptom discordance that's observed in population studies. So what other things are causing pain in people with knee osteoarthritis? Well, a very early study piqued my interest when I started to get into this area. And this I took as indirect evidence of central pain mechanisms. This was a trial of intra-articular lidocaine injection 20 years ago now. So as expected, the intra-articular lidocaine injection reduced pain. What caught my eye was that the non-intervention contralateral knee also had pain reduction. So how could a directed treatment for one knee improve pain in the other knee. And that started to get me thinking about central pain mechanisms. Now, in 2012, Thomas Graven Nielsen and his team were studying pain sensitization in osteoarthritis. And in this figure that I'm about to show you, they found that there was lower pressure pain threshold, one of the quantitative sensory testing means of assessing sensitization in people with osteoarthritis than healthy controls. I put healthy controls in quotes here because healthy controls means they didn't have OA and they didn't have pain. So we don't know what's driving the difference. Is it the OA, is it the pain, or the combination of the two? So nonetheless, they had a small sample, 48 with OA, 21 without OA. In the black bars is OA. And you can see consistently across all the sites in the knee, the pressure pain threshold is lower, meaning more pain sensitized. In addition, sites away from the knee, the arm and the tibialis anterior also had lower pressure pain thresholds, and also on the contralateral side to the knee with osteoarthritis. So this seems to indicate that there's this global pain sensitization in people with osteoarthritis compared with people who don't have any pain or OA. Patrick Finnan, around the same time, did a series of QST measures. And in this one particular part of this paper, they looked at mechanical phasic pain severity, which is equivalent of temporal summation. And they found that people who are discordant, the high pain and low structural severity, had greater temporal summation. So this is starting to identify this structure symptom discordant group as maybe having central sensitization contributing to their symptoms. So we started looking at all of this around the same time, but in an exponentially larger group. This is the multi-center osteoarthritis study, which is a cohort of about 3,000 older adults with or at risk of knee osteoarthritis. And when we first started assessing QST, we used pressure pain threshold within a handheld algometer and temporal summation using a series of weighted mechanical probes. And we focus on mechanical stimuli because OA is thought to be largely biomechanically driven, though biochemically, biologically mediated. And so in a series of studies, we found that pain sensitization by these measures were indeed associated with greater pain severity. We hypothesized that greater OA severity, structural severity, should be associated with more pain sensitization, because we thought that more nociceptive drive from structural pathology would increase the likelihood of having sensitization. And much to our surprise, we did not find that structural severity was associated with pain sensitization. So then we thought, okay, well, maybe it's not necessarily structural severity, but we also have to take into account the time over which someone's having this nociceptive drive that might sensitize them. But we also did not find that duration of osteoarthritis to be associated with pain sensitization. We also thought, well, maybe radiographs are too insensitive because it's an amalgamation of all sorts of pathology. So then we looked, oh, I'm sorry, I don't know what I just did there. Hold on. So then we looked at MRIs, and in animal models, joint injury and joint inflammation have been known to induce sensitization. So what we found was that evidence of inflammation, either through synovitis or effusion, was associated with that inflammation was associated with pain sensitization, but a more biomechanically mediated lesion, bone marrow lesion, more of a mechanical lesion, bone marrow lesions, were not associated with pain sensitization. So we were trying to put this all together, and this is when we first started to think about state versus trait. And we initially went into these studies thinking that sensitization was a state induced by OA pathology. But taking these findings into account, we started to think about whether or not it truly was a trait inherent to an individual. So then Lisa Carlesso, who's at McMaster University now, she came and worked with me as a postdoc, and we started to look at pain susceptibility phenotypes. So we took people who are free of persistent knee pain at baseline, about 850 people, and we took a bunch of measures that we knew influenced the pain experience. So our QST measures, evidence of widespread pain, mood alterations, poor sleep, and we did an agnostic analysis, latent class analysis, and we found that these 850 people roughly grouped themselves into four different patterns. One group was highly sensitized by pressure pain threshold, one group was highly sensitized by temporal summation, and the other two were much less. What surprised us is the four groups were not differentiated by existing widespread pain, pain catastrophizing, depressive symptoms, or poor sleep. So while those factors influence the pain experience, they didn't differentiate between these groups. In this analysis, what we found was that this group that was most highly sensitized based on measures of pressure pain threshold, they had a twofold increased risk of developing persistent knee pain over 2 years. And so these findings have important implications for understanding factors that contribute to the transition from acute to chronic pain. People may be predisposed. So then Kosaku Aoyagi, who's now at Ohio State University, he came and did a postdoc with me, and we further interrogated this concept of trait versus state. So by this time, we had 9 years of QST data in the multicenter osteoarthritis study. So we conducted an agnostic group-based trajectory analysis in just over 1,200 people. And we really expected that there would be a change in pressure pain threshold over time, over almost a decade. But what we found was that pressure pain threshold in both men at the bottom, women at the top, was rock solid stable over 9 years. And they roughly, we labeled them as high pressure pain threshold, least sensitized, to low pressure pain threshold, most sensitized. And they were, very quite distinct. And this surprised us that this was so stable despite changes in their OA stages over time, probably treatments they've tried over time, and comorbidities that they might have accrued over almost a decade. And then we thought, well, let's see if these trajectories are actually clinically relevant. And what we found was that indeed, in relation to pain and function, the trajectories over time did also have a strong relationship with pain and function. So these trajectories are clinically relevant in terms of their clinical presentation for pain and function. So then Lisa and her PhD student, Raghava Nilapala, and I started to look at, okay, can we understand if pain phenotypes transition over time in people who are at risk of OA? So before they develop OA, these baseline pain phenotypes that we can identify, how do they change over 7 years? And so here's this beautiful alluvial plot. We identified three classes that had different sensitization, psychological factors, and widespread pain. And what was really surprising to us, and what you can see with these alluvial plots, is that 86% remained in the same group over 7 years. So again, kind of contributing to this concept that these pain phenotypes seem to be inherent traits in individuals. And just to briefly show that my colleagues, collaborators in Norway, in their NORHAND study, a cohort of established hand OA participants, we're doing the same types of studies and we're finding the same types of patterns in hand OA. So 80% are remaining in their baseline phenotype class over a 3 to 4 year follow-up period. So what may underline a pain sensitization trait? And of course, our mind goes to genetics. And this really lovely study that was published a few years ago now in Pain looked at 24 pain conditions in the UK Biobank in over 400,000 participants of the UK Biobank. And to just briefly summarize these four figures that I've copied here, they conducted a genetic analyses and so there's a lot of sort of interrelationships. They conducted a factor analysis and they found two factors that were loading here. One was a general factor across all 24 conditions, and another factor they labeled as MSK, factor 2, which really loaded on MSK conditions. And then they conducted a network analysis where they again showed substantial genetic overlap with 19 interconnected conditions. And so this lends credence to our more recent interest in studying chronic overlapping pain conditions. And arthropathies, which is mainly OA, back and neck pain, were highly interrelated with many of these other conditions. So what does this all mean? Some, but not all, pain in OA is due to structural disease. Other pain mechanisms must also be addressed. We can't just focus on the peripheral joint. because pain sensitization may predispose individuals to a more severe clinical picture and merits targeting. But how to target the right pain mechanism? I'm just going to end here with this hypothetical for people who have different contributions to their pain. OA, structural pathology contributing to nociception, pain sensitization, psychosocial factors, and widespread pain. If you have a drug targeting an OA structural pathology pathway, you want person 3 and 4 in your study, not person 1 and 2. But we need a way to validly phenotype their pain to enroll them into trials. And so in summary, pain is multifactorial. Pain sensitization may be predisposing in some. We need to have disease modifying and pain management options and a mechanism-based approach to management. And with that, I acknowledge our funding, our colleagues, and anyone in the US interested in training. This is our T32 program. Thank you.
Brilliant. Thank you very much, Tuhina. So if anyone has any questions, please put them into the Q&A. There's been a couple that have already come in, which I'll ping in your direction. So somebody asks, if OA patients have a muscle pain component, is that related to any change in muscles or outside the joint structure? And if so, how can you pick that up if you're focusing on the knee joint?
Right. So that's a really good question. And this is an area that we're now focusing on, and other groups have started focusing on that the muscle quality hasn't been fully studied or hasn't adequately been studied in OA. There's obviously with functional limitations, there's muscle weakness, poor quads activation, etc. Probably intramuscular fat contributes. So OA needs to be looked at as a whole organ disease, not just intra-articular, but also muscles, ligaments, tendons, etc.
And that segues brilliantly into the second question, which is about this, how systemic is OA? So someone asked about inflammation during OA in terms of how much that is systemic versus just within the joint. Is it a bit of both? Would you care to comment on that?
Yeah. Out of respect for time, because that could be an entire talk on its own, I think it's a bit of both. And, just as an example, people who undergo bariatric surgery, not only do their lower extremity joint pains improve, which you might expect from decreased loading, but also hand pain improves. And we're going to learn a lot more with the GLP-1 receptor agonists in terms of systemic. But I'll also say we've published a while back that visceral fat does seem to be associated with pain symptoms in OA.
Great. And then just one final question, sort of towards the end of your talk, you're showing about, these 4 different hypothetical people and how you might want to treat them. And someone's just asking about what does the current evidence suggest for a personalized treatment approach? Are we able to assess our patient within, a couple of minutes and go, this is a thing for you? Or are we still at the point where we've got a paucity of treatments and it's just suck it and see? I mean, and again, that's probably another talk in itself again. But yeah, if you could just comment a little bit on where we stand for personalized treatment at the moment and where we might be in a few years' time if things go well.
Right. So we actually have a lot of very effective treatments, physical activity, weight loss, physical therapy, rehab. It just has to be multimodal. And the issue is the pharmacologic therapies is where we have a paucity, and we need a lot of research. And symptom management, we need safe, effective symptom management. NSAIDs, over half of older adults can't take NSAIDs or have contraindications, precautions. So there's a lot of need, but we also have underutilization of some things that are available. So there is ability to do some personalized approaches, but not anywhere where we need to be in terms of a disease modifying approach.
Great, thank you very much. And yes, I think my inner pharmacologist came out when ignoring everything else that wasn't pharmacology. Thank you very much, Tuhina. Okay, we will move on to our third and final speaker of the session, who's Niels Eijkelkamp. He undertook his undergraduate and postgraduate degrees in the Netherlands, alongside training in the US and the UK. He's been leading his own group at the University Medical Center in Utrecht since 2013, and is currently Professor of Immunology of Pain at the Center for Translation Immunology. His research focuses on chronic pain, and in particular for musculoskeletal conditions, where his work has focused a lot on how different immune cells and cytokines can regulate sensory neural activity, which is what he's going to be telling us about today for both mice and humans. So Niels, over to you. Thank you very much.
Thank you very much, Ewan. Thank you also for being here, that I can present some of our work. And as Ewan was saying, I hope to show you a bit of the work that we've been doing on understanding what is driving osteoarthritis pains, and I will share some data from mice and human. And I think that's already highlighted. There's a clear structure pain discordance in osteoarthritis. But if you look at it from a basic, simple level, we have tissue damage in a knee joint, for example, and we know that inflammatory mediators, but also damaged molecules can directly activate nociceptor endings, leading to pain. However, one would expect that if the tissue heals, for example, that pain would disappear after the dissipation of these inflammatory damage drivers. And I think it's becoming quite clear that, for example, in osteoarthritis, 10 to 40%, with an average of 20% of osteoarthritis pain, remain to have pain, even though that the knee has been replaced, suggesting that there's other mechanisms that are actually driving this pain. And that's exactly the point where we're interested in understanding what are those mechanisms that are driving this persistent pain in osteoarthritis that might be potentially in discordance of the structural damage that is in the knee joint. So to start off, some findings that we have done in mice is using experimental models of osteoarthritis models. And in this particular case, where we do intra-articular injections of monoiodoacetate, which damages the cartilage. Well, but a striking thing that we found is that, especially in the ipsilateral sites, in the dorsal root ganglia that contain the sensory neurons innervating these damaged knee joints, we see an increase in macrophages. And you can quantify this, and these macrophages are increased and persist over time, at least for 4 weeks, as long as we measured. And interestingly, if you look at the phenotype of macrophages, as they can have more inflammatory phenotypes, tissue healing phenotypes, the striking phenotype that has is that they're mostly expressed inos, which is suggesting of a more inflammatory phenotype. One could, of course, as also being mentioned a bit earlier, in experimental models, is this not a funky artifact of this particular model? So we did this also in another species, actually, in a completely different osteoarthritis model in which rats are obese, fed with high-fat diet, and we induced damage to the knee joint by grooving the femoral condyles. And what was striking to see is that these rats develop pain, but we also saw an increase in these macrophages in the dorsal root ganglia, suggesting that this is at least happening across species in these experimental OA models. So the big question then, of course, pops up is what are these cells doing there? And to tackle that question, we went back to transgenic mice that allow us to specifically deplete these macrophages and monocytes by using transgenic mice where monocytes and macrophages specifically express the diphtheria toxin receptor, allowing us to deplete macrophages, specifically also in the DRG, with intrathecal injections of diphtheria toxin. And what was striking to see is that in these mice where when we induce osteoarthritis with this monoiodoacetate model, 3 weeks after the induction of pain, we injected diphtheria toxin to deplete these monocytes and macrophages, and we see that the mechanical hypersensitivity that we measure in this case with von Frey is completely disappearing, suggesting that we really need these monocytes and macrophages in the DRG to maintain pain. And actually, if you would replace these with wild-type macrophages, you see the reoccurrence of pain again, really suggesting that we need these macrophages. So, as I just showed, we saw that these macrophages in the DRG have a more inflammatory phenotype. So we questioned, so if you start inhibiting this inflammatory phenotype of these macrophages, would you then stop this pain in osteoarthritis? And to that end, we wanted to use cytokines, and specifically a fusion protein of cytokines. I won't go into details, but basically this fusion protein of IL-4 and IL-10 is very potent in inhibiting macrophages or monocytes in their inflammatory phenotype. So as an inhibitor of these macrophages, with the idea, can we then suppress these macrophage activity in the DRG? So what we did is we went to an osteoarthritis model, again, this Maya model. We let the mice develop experimental osteoarthritis and then did an intrathecal injection of these anti-inflammatory cytokines intrathecally. And then addressed whether we could reduce the phenotype of these macrophages from an inflammatory, as you can see here with the inos expressing macrophages. We can see a reduction in this, suggesting that the inflammatory phenotype is reduced. And strikingly, we could also see that this pain phenotype was completely inhibited by this fusion protein, suggesting at least to us that if you inhibit this inflammatory phenotype of macrophages in the dorsal root ganglion, you also reduce these pain-associated behaviors in these experimental OA mice. The question, of course, drops off, why are these macrophages coming into this inflammatory state? So we tested this in vitro by using sensory neurons from either the contralateral side or the ipsilateral side and co-cultured them with macrophages and asked a simple question: what is happening with the phenotype of these macrophages? What you can see here is that what's striking to see is that only if we co-cultured them with the ipsilateral sensory neurons that were innervating these damaged knee joints, we could see that these macrophages were driven into a more inflammatory phenotype. So that opened us the question to answer: what are these sensory neurons then making that drives these macrophages in this pain-maintaining phenotype? We did some transcriptomic analysis, which I won't go into detail, and actually we identified various immune-related factors. These range from IL-18 and the NLP inflammasome, which I won't say much about, but also myostatin. We got our interest in myostatin because it's a very well-known inhibitor of muscle growth. So if you have animals that are myostatin deficient, they have very strong muscular growth, as you can see in this cow on the right. So when we looked in the DRGs over time in this experimental osteoarthritis model, we saw a significant upregulation of this myostatin being expressed by sensory neurons over time. So suggesting that indeed these sensory neurons start making myostatin in this experimental OA model. Big question, of course, is what is this myostatin doing, for example, to the phenotype of macrophages and, of course, the pain behaviors that we see in this mouse model? So we did various experiments, but I just want to highlight one. Again, we induced this experimental osteoarthritis and give an anti-myostatin antibody to neutralize the myostatin in the DRG. And what was striking to see is that after 3 weeks of development of the experimental OA pain, if we give these intrathecal injections, we could completely ablate this mechanical hypersensitivity, suggesting that this myostatin is required for the development of this persistent pain. And interestingly, this was also associated with a reduction of this inflammatory phenotype of macrophages in the DRG. So, to make a longer story short, so what we showed is that these macrophages actually accumulate in the DRG, and various factors, of which I showed myostatin, but we have also shown IL-18 and NLP3 activation, actually start driving these macrophages into a more inflammatory-like phenotype, and those macrophages then maintain pain independent of the original knee joint damage. But this is, of course, mice. And is this also happening in humans? Well, big question is, we don't know yet, but we're trying to investigate, can we identify similar or discordant or different mechanisms that are also happening in osteoarthritis in humans? And to that end, we have gained different cohorts of various patients, as highlighted here, with detailed pain questionnaires, but also with quantitative sensory testing and cuff algometry. And I just want to show you some of the data that we obtained with these studies. The first one is actually another cohort of the EME approach cohort, where we used the pain detect questionnaire to kind of differentiate between the types of pain. And using this neuropathic or pain detect questionnaire, we wanted to capture neuropathic pain features versus kind of nociceptive pain features, just based on the questionnaire. But what the striking thing is, if we selected those patients scoring high on this questionnaire and compared them to matched patient that scored low in this questionnaire, what was striking to see, although they had the same level of pain, there was clearly a discordance with the amount of radiographic damage, with lower KL grades, a larger joint space width, and less osteophytes, suggesting that this neuropathic pain feature is associated with less gross radiographic damage. So thinking of this, we kind of hypothesized that if patients that are undergoing a total knee replacement and score high on this pain detect questionnaire, or they are likely not to resolve from pain, and those that are scoring low, they will resolve of pain. We tested this in a specific different cohort where we followed prospectively patients, 75 in this case, that undergo total knee replacements for 1 year. Just some highlights of this study is that we show that indeed approximately 20% of the patients remain to have pain 1 year after the total knee replacement, and compared to the other 80%. And what is striking indeed to see is that those patients that score that resolve pain have a relatively lower pain detect score than those that are not resolving. So coming along with this, we use this pain questionnaire in a different cohort of which we have collected cerebrospinal fluid to answer the question, can we identify various immunological factors that could distinct those patients with osteoarthritis that score higher on the pain detect and low. And this is basically characteristics of this cohort, showing again that the pain magnitude is the same, but they score really differently on this pain detect questionnaire. So when we did this, and I just want to highlight this, when we did this O-link assay of all different factors within the cerebrospinal fluid, we identified various factors that were able to make a distinction between those groups. And not going through all of them, but there's various immune factors like CXL9, also IL-18, which we also identified in mice, and LAIR2. And actually, some of these factors we're now validating again back in mice studies, of which LAIR2 is also one. And there we identified that LAIR1 is actually a very important inhibitory receptors that is regulating resolution of pain induced by inflammation. Okay, so that is what we identified in the cerebrospinal fluid. But the big question is also what is happening, for example, in the synovial tissue? Can we also there detect different factors that are related to the magnitude of pain in osteoarthritis? So in this case, we went for a little bit of a different approach. We selected 4 to 5 patients that are scored high on pain with osteoarthritis and some low, and we did mass spec analysis of the synovial tissue. And to our surprise, the major factors that popped up were complement, as you can highlight here. We validated those complement factors also in a different cohort of 24 patients, where we actually looked at the association between complement expression and the activation of complement with various pain scores, and saw that some of them were positively correlated with pain. And this was striking because if you look at the classical pro-inflammatory mediators like IL-1, TNF, that were produced by the synovial tissue, they correlated not or almost negatively. So we followed up on this, and we identified that basically, if you look at, we wanted to know whether this complement is important. And complement factor C2 is basically a crucial crossroad of complement activation by the classical and lectin pathway. So when looking at this, we looked at C2 knockout mice. Oops, is it lost now? My screen flips. Oops.
No, we can still see your screen.
Okay. Well, then assuming it's still okay. We looked at C2 knockout mice basically to see whether that would be important in pain. And we looked at different pain behaviors, the von Frey test, the dynamic weight bearing, and conditioned pace preference. And basically all these outcome measures show that if mice do not have C2, they do not develop persistent osteoarthritis pain, suggesting that this complement factor is required for the development of persistent pain. And we did the same thing also with an antibody neutralizing it. I'll skip that because it's time. So what I've hoped to show is that sensory neurons drive macrophage programming towards an inflammatory phenotype that maintain pain, and that by using human studies, we can also identify various factors, including some immune-related factors like complement and LAIR in OA. And currently, we're also trying to investigate whether there's a link, what we see in a knee joint happening compared to the macrophage in the DUG. And of course, I want to thank all these people in the group and the funders. Thank you.
Thank you very much, Niels. Okay, so if people have any questions, please put them into the Q&A. There's one that's come in, which I can ping in your direction straight away, which is if you could comment on sex differences you have or haven't observed, either from the mouse work about the macrophage infiltration or the...
I assume yeah. Yeah, you broke up, but I got the question. So sex difference. If you look at the macrophages, yeah, if you look, there may be very subtle differences in the number of macrophages that are there, but depleting these macrophages either in females or males has exactly the same effect. So that is not different. If you look in the human studies, there is a clear sex difference. For example, if you do an unbiased analysis of these proteome analysis, we saw 2 different clusters. And only in the females that these different clusters had different, for example, pain scores. So there seems to be some sex differences in there. So that depends a bit. So in the humans, yes, we do see it if you look at the global levels of these factors that we measured. But in the mice specifically for macrophage, we did not see any differences.
Okay, thank you very much. Any other questions? So a couple of minutes if you want to ping a question into the Q&A. Because there are a few others, but they're to do with arthroplasty, which I think would be unfair to ping in your direction, Niels, not being an orthopedic surgeon. Or you can take them on if you wish to.
You have to read it. Okay. Yeah, I can read it.
Well, I guess one of the key things is about arthroplasty in terms of those people who, after arthroplasty, still have pain, or those who don't have pain. What might that tell us about the DRG primary signaling or central sensitization pathways?
Well, so first of all, I think, for example, this pain detect question, it can really help if you could do that beforehand, because basically the data suggests that if you would use that, don't do the arthroplasty in those patients. And to be fair, if we also have looked now in this new cohort to see whether there are differences, at least in the cerebrospinal fluid, of those that will be recovering and not. And there we do see clear differences. Well, clear, small, subtle, but significant differences between those that are not resolving from the total knee arthroplasty versus that do. Whether that will be sufficient to really distinct those two groups at before the total knee replacement, for example, I don't think those differences are too big, but on a group level, there are some differences.
And I think we have time for one final question before I pass over to Adam. So final question from Michael Gold. Says, very interesting data. Apologize if I missed it, but have you identified what's released from DRG to drive the change in the macrophages? And does it occur in the DRG and knee, just the DRG, just the knee?
So short answer is we don't know. So I think there's different things happen in the knee joint. The hypothesis that we're now trying to answer is that, for example, this complement activation in the knee joint activates the nociceptors that then will lead to, for example, these factors like myostatin that are produced by sensory neurons, and that is then released in the DRG that drives macrophage activation. But that actual link between the periphery and what's happening in the DRG we haven't shown. So that's at this moment just hypothetical.
Brilliant. Thank you very much, Niels. And thank you to all three of our speakers. I'll pass back over to Adam now to close the session.
Yeah, thank you all so much. What a wonderful session, and thank you for the engagement from the audience. Very, very helpful and enlightening questions. That will go ahead and conclude our session. Again, thank you for attending, and we will see you all at our next webinar. Thank you.